Hi, I'm Dr. Vera Tarman, and I am a medical doctor who's interested in addiction and especially interested in food addiction. Now, today's talk is going to be a specific area about food addiction, but just to give it as a background, a couple of days ago, I talked on food addiction, the general idea of what food addiction was, hoping that people might be able to relate to that concept. And in the whole realm of food addiction, one of the areas that we're interested in is the solution. What do we do? And this is the talk where I'm going to look at basically what we don't want to do, but is what is offered to us. So if you're somebody who is struggling with extra pounds, obesity of some level, if you're struggling with food issues where you're overeating in a way that you wish you couldn't, and is there some way that you could work it out? If you go to a doctor and try to find out what to do about that, most likely you're going to be given two basic solutions, which I want to talk about today. And those are bariatric surgery and medications. Medications for obesity or for managing overeating. And what I'd like to do today is talk about why those are useful to some degree and then why they're not enough. So in other words, the topic of the day is there's no silver bullet for this issue, but it's good to know what the options are, what the offers are, so that you can then add further to your knowledge, which is basically to understand about food addiction. But if you don't understand about food addiction, these are not enough of a solution. But let's look at what the solution is, the sort of standard medical solution. So I'm going to turn on my slides and I'm going to start talking about this. But for those of you who are listening, and I've already joined on, please be aware that the subject for today is I'm going to do this talk for about a half an hour. And then after that, there'll be a Q&A to take questions about this subject of surgery and medications. And then at the very end of that, I've got a very exciting announcement that I'd like you to wait on and hang on for. Because if you find this information really interesting, you're going to find my announcement very interesting as well. So please hang on. Okay, so the topic today is called a no silver bullet: medications for obesity and surgery and medication for obesity. So when we talk about the options of surgery or medications, I want to first of all introduce this concept of the body mass index. This is a clinical term that is recognized as not being the best term or the best way to determine a person's weight, but it's the currency, it's the common language that all clinicians use. It's where you are in the body mass index determines what type of surgery you will or will not be allowed, what type of medications you may get covered by insurance or you won't get covered. When is something considered cosmetic surgery? When is something considered actually health-related surgery? Is all about the body mass index. And the first thing I'm going to say is that's basically an issue for food addiction, obesity, and for people struggling with eating. But the food addict, it's not about a body mass index. Anybody, any person of any body mass index can be a food addict. And so already we see that the tool that we use to define where somebody sits and what kind of surgery or medication that they may warrant, that essential diagnostic tool is not even enough for the food addict. It's just not, it doesn't cover enough. But anyway, basically the body mass index is a term that is determined based on a person's weight and height. And it's very easy to get the tool on the internet. You just plug in your weight and your height and you'll figure out where you are. And a normal body mass index is between 18 or 19 and 25. And that's the green in the middle here. That would be the what's considered a normal weight. And then underweight is under 19. And then basically overweight is 25 to 30 and obese is 30 onwards. Most of the surgical and medication-related treatments that are covered by insurance plans, you have to be in the obese category or more. And just for interest's sake, in our American, Canadian, sort of Western world, we have already now 2/3 of the population that would fit that criteria of either being overweight or obese. And how many are in the normal population? It's 1/3, and by 2025, it's estimated it's going to be only 1/4. So medication and obesity as options to deal with basically an obesity crisis in the Western world, we're going to hear about more and more and more, which is why it's good to know what's out there on offer and also what the limitations are, which is fundamentally what my purpose of this talk is to say, yeah, this is good, but there are limitations. So when we deal with a person who's got a body mass index of 30 or more, which is obese, or 25 plus, which is overweight, generally speaking, there's three. You see the pyramid here of surgery at the top, pharmacology in the middle, and lifestyle modifications at the bottom. Generally speaking, the higher the body mass index, the more likely the person will qualify for surgery or pharmacotherapy. From the get-go, right, regardless of where you are, there's always the talk in the medical world about diet or weight loss, or basically exercise. It's the calories in, calories out model. And if you're listening from a low-carb point of view, because I'm imagining a lot of you who are watching this video right now, or this talk right now, are already quite aware, quite educated about what foods are good and not good. So you're already quite aware of the lifestyle modification angle, and you're already aware probably that the medical response has been quite slow in recognizing that it's not just calories in, calories out, but the specific calories, in other words, the carb calories, that make a big difference. So we're already ahead of the game in this bottom line here. But anyway, this is still where people are suggesting. But actually, more and more, the medical world, because the medical world not recognizing the importance of low carb, are seeing that it's just not helpful. Because since calories in, calories out doesn't really work, we're recognizing that maybe we shouldn't really focus on that side because it doesn't seem to work. Well, as an aside, it doesn't work because it's not accurate. But anyway, aside from that, doctors are generally saying, okay, what's the next tier? Well, that's the pharmacotherapy tier and the surgery tier. These are the pieces that I'm going to talk about specifically today. The surgery tier at the top, I'm going to start with that because it's the most effective immediately. And if a person, and also we want it to be the most effective immediately because generally speaking, the people who qualify for this are the people who have, as you can see, their body mass index has to be quite, at least in the obese category. Okay, sorry, I'm just going to stay here now. And although you can get this surgery with a normal, I mean, why would you if it's normal? But if you're overweight, it would be considered cosmetic surgery, and you're likely not get it unless you have some indicators like you're already diabetic or you already have high cholesterol or what we call the metabolic syndrome indicators. If you have a couple of those, you might qualify. But anyway, the first one, that's probably the one that people know the most, is the lap band. And that is, it's a surgical procedure, but it can actually be an outpatient surgical procedure. It doesn't have to be in the hospital. You put a lap band in, and well, I'll tell you in a second what it does. It constricts the amount of food that can go into the stomach. But, it's a band that's sort of strapped around the stomach so that instead of having a full stomach, half of it is sort of functional. So you're really decreasing the amount of stomach that's available. And you can adjust that so that if the lap band is too tight or it's not tight enough, well, you can basically adjust that. And often people will get a readjustment because what happens if they're not changing their food, they actually end up stretching the little bit of pouch that was there until it almost resembles the previous size, and then you've got to do another lap band procedure. But anyway, that's a fairly, if I can say, quick and dirty way to get surgery, and is fairly effectively, at least initially. All of these things are, I'll talk about efficacy in a minute, but all of these things are fairly effective on the initial grounds. Whoops, sorry about that. The next one is what's called the Roux gastric bypass. And that one, along with the next three, the vertical cervical sleeve, the vertical sleeve gastrectomy and the duodenal bypass. These are all different levels of and different mechanisms of basically bypassing the intestinal system. We have the small intestine. The stomach is the first place where the food goes. So if you restrict that, you're restricting the amount of food that you're eating. But then the intestines actually, the small intestine, which is, it goes from the stomach to the small intestine. The small intestine is what begins to absorb the food, hence the potential weight gain. And so the different types of surgery are ways to bypass that small intestine or make it less so, or do a little bit of the vertical sleeve, where you're reducing the stomach and some of the small intestine, basically trying to operate on the two different ways that this surgery works, which is inhibit the absorption of the food from the small intestine, or just plain obstruct the amount of food that is in. You just can't take that much in. And that will mean less calories ultimately into the system, which means then less weight. If I can just say as an aside, because I know I'm speaking to an educated audience, that we know it's not just about calories, it's about what type of calories that we're eating. So how much does that work? I don't know. And think about it. If you've got a small pouch, or you've got a surgically altered intestinal system, you're not going to be able to eat the raw or real vegetables that you would have been able to eat before. You're not going to be able to eat the Brussels sprouts and the broccoli, or not the amounts. Or if you do, you're going to have to mash them down into some kind of slurpy substance so that you can actually take it into your belly, into that stomach that's been altered. And therefore, essentially, you're going to be eating foods that are more refined, more processed, which are actually, from a food addiction point of view, the most dangerous of foods for in terms of addiction. So you're kind of setting yourself up in a negative way. But let's look at, this is how it works. So just to go on with this slide, how it works, it inhibits the amount of food that can go into the stomach and the intestine, and then decreases the absorption. So what's the success? We'll look at the success first. And here's why bariatric surgery is considered the gold standard of obesity treatment, even more so than medication, because it actually, you can lose quite a lot of weight. Now look at this, 30 to 50% weight loss in the first year, and certainly by 5 years. That's a lot of weight. And if you're somebody who is morbidly obese, like 400 pounds plus, and you don't have the patience to do a food addiction plan, for example, or a low carb plan, where you'll lose weight, but it might take a couple of years, you might not last that long, quite frankly, because your parameters, diabetic parameters and cardiac parameters, are so taxed that actually bariatric surgery might give you that time that you need. So on that level, I can't argue with that. It gives you quick results. At a cost, of course, which is the surgical manipulation, which causes lots of side effects. But I want to highlight that there is a benefit. Now, if you aren't aware of the concept of food addiction, or even low carb, the idea that it's not just about calories, what happens? And this is typically what happens in year 3 or year 4 post-surgery. What happens is you'll get weight regain. Now, you may not gain it all back, and success is considered that you have at least maintained 30% of your weight loss. So weight regain can happen. It often happens. And in fact, by 10 years, less than half of the people who have had surgery will have maintained 30% of their loss. Even though they lost 50%, some is regained, but 30% is lost. I mean, is gone. So it's still quite a significant chunk of weight loss. But it's, there is this concept of weight regain. And that's a small proportion of that population, and I see these people in my office all the time, the food addicts, gain all of their weight back and some. And boy, is that ever disheartening and discouraging. And we see people going back for secondary surgery, or they just go back. So the positive effects are that you do get a response. Whoops, I'm sorry, I don't want to go back to this. You do you do get effects. You get weight loss. There's no question that diabetes can actually be halted. I'm not saying it goes away, but it can be halted. Metabolic syndrome can be quieted. Cardiovascular indicators are better. So COPD, the difficulty breathing, sleep apnea, arthritis, mood disorder, depression, these things can get better. Yes, they can. However, if you don't follow the food plan that they themselves will, not all of them will give you a good food plan, but some of them will say, hey, you got to, stop eating refined foods and stop eating sugars and whatnot. That's not their main focus, is to talk about that, but they might. But if you don't get the concept of food addiction, it's quite likely that you're going to be eating that stuff anyway. Because the side effects of this is, not only are you not absorbing all the nutrients, for example, vitamins, because you have surgically altered your ability to absorb foods, not only is that being altered, you have post-surgical consequences that can happen, but you're also more likely to get addicted to things that are highly refined. Now, what's the most highly refined of sugars? Alcohol. Alcohol is basically fermented sugar. And we see that people who have had bariatric surgery have a higher tendency to become alcoholic. And although we haven't researched this, it's, in my experience, food addiction, because it's basically the refined sugars. What else are you eating but these refined foods? And so you're more likely to get hooked more quickly than somebody else. An example, if I can just say it, if it takes a person with a normal, like a non-surgical patient, drinks alcohol, a post-surgical patient, a post-bariatric surgery patient, that's equivalent to 3 drinks. So they have 1 drink, they're sitting at a bar with somebody else who has 1 drink, it's as if they've had 3 drinks. So they have 1 chocolate bar, it's as if they've had 3 chocolate bars. So it's basically, because of the potency, whatever is left to absorb, it will go always for the most refined. And of course, that's the highly potent addictive foods. So bariatric surgery is good, but if you don't understand the concept of food addiction, you could actually get yourself into more trouble, or certainly it's not going to help in the long term. After 5 years, we see a lot of weight regain, often even in the year 3. Okay, now I want to get to medication, because I want to make sure we talk about that. So surgery is considered a very good option because it's quick results, but then it has a lot of consequences. So how about just let's look at medication. Are there medications that can help for obesity and that can help for controlling food intake? And yes, there are. There's a number of categories of them. And over the last 50 years, there's been some decades where more have been in favor of than in others. So for example, if you look at the top here, appetite suppressants, that would be an early one in the 50s, was used a lot. It's still used now under the name, under the very popular drug called Vyvanse. I'm going to talk about these in specifics. The fat absorption drugs like Orlistat, very popular maybe 20 years ago, not so popular now. The exciting one that people are talking about when they say, hey, there's new medication coming up, they're usually talking about the hormonal based drugs, and that would be like Metformin, Saxenda. I'm going to talk about all of these. Also, there's the antidepressants and mood stabilizers and the craving blockers. So you can see there's a bunch of different categories and lots of, if you're a pharmacologist, exciting work in these areas for obesity. Although I will say, in the overall picture, obesity medications has been somewhat exciting, but lots of drawbacks, and so it's a hot and cold kind of area. People get very excited and it's that didn't work, and then there's no excitement, and now we're back on the cusp of something exciting because of the hormonal focus. But let's go back, like basically in the 1950s. Medications that existed. So Dexedrine, I don't know if you remember that drug. For those of you who are as old as I am, these were the bennies. These were the speed pills. These were the pills that basically caused, I'm just going to show you here the effects of that. They suppressed the appetite. They increased body metabolism. So the idea is that you don't want to eat, plus you're burning off more fuel. And so therefore you're going to lose weight. And sure enough, that worked. It worked quite well. And in terms of, I would say, I'm not going to suggest that this is an option because of the drawbacks, but out of all the ones I want to suggest to you today, it is probably the one that's the most effective are the amphetamines. You can gain, lose like 10 to 15% of weight, of your weight from these, but it's at a cost. So the bennies, Ritalin, it was very popular in the 80s and 90s. I mean, it's used for attention deficit, but it's also used for appetite suppression. The most recent thing that we're talking about is Vyvanse. Vyvanse is a drug that's used frequently for um, oh my gosh, attention deficit disorder, but in the food addiction world, not the food, but the food, basically the binge eating disorder world, the difficulties with binging and eating, Vyvanse is used not as a appetite suppressant, not as a increasing of metabolism, but the belief is because it's a drug that's meant to be for attention deficit, it supposedly helps for impulse control, because that's what attention deficit is inability to control impulses. It's one of its main symptoms. And so if you can kind of target on that, then a person with a binge eating disorder will not, they'll have more control of their impulses. At the same time, they will have suppressed appetite and increased metabolism. Ephedrine is something that was used a lot in the 80s, 90s, and somewhere around the 2000s, it got taken off of the market. It was a herbal supplement that was used, and in a lot of things, and it got taken off of the market because it was seen as abusive and not healthy. So I don't think it's available now, although its cousin, pseudoephedrine, which is what you can get when you get contact C or some kind of a medication for your hay fever or allergies, is, if you don't know it already, it's the fundamental ingredient of crystal meth. So ephedrine, you can see, is these are all linked together in some way. And crystal meth is, I have here, partly as a joke, not really, cocaine and crystal meth are also very effective ways to lose weight. In fact, I work in the addiction field. We have a joke that it's the Jenny Crack system. It's a way to lose weight through drugs, and it is actually something that a lot of people who use drugs, get off of drugs, gain weight, say, you know what, I'd rather go back to the drugs rather than have this weight. So even though I'm not advocating this as a weight control, it is one that's used. And of course, there's our friendly tobacco. And, we know this from even before the 50s, Virginia Slims, all of those, tobacco. We know that when you quit smoking cigarettes, there's a typical weight gain of 7 to 10 pounds. And that's just metabolic. It's not because you're eating candies instead. Okay, so that's the amphetamine. And why do we not want to use this? There is a significant weight loss, but it does create insomnia and anxiety. Higher doses absolutely creates paranoia, and that's what we see with crystal meth and cocaine. And, overuse of those dexedrine pills. Like if you're taking Vyvanse at the level that you're supposed to, not likely, but, people will abuse that stuff. And cardiac tachycardia, which is increased heart rate. It puts your level high, and, it's not very good. Now, the problem with it is when you stop taking that drug, you gain the weight back. And this is one of the drawbacks. Okay, the next one is psychotropics, or basically psychiatric medication. That's not others that I'm suggesting here. So the SSRIs like Prozac and Celexa, these are the antidepressants. We have antidepressants that are more of a mix, the selective norepinephrine reuptake inhibitors like Effexor. We have other drugs like Wellbutrin or bupropion or topiramate, which is a seizure disorder medication. These are all on some level. The theory behind the, let's just see, I've got this here. The SSRIs is, the antidepressants is, well, if you're eating because you're depressed or you're lethargic or you're anxious, then treat the condition and then you don't need to eat as much. Or it might actually suppress appetite in some way. So the antidepressants mainly to treat a mood disorder that's underlying. The SNRIs tend to be the same reason, but they're weight neutral. Wellbutrin is also weight neutral. It does the same thing. It treats the medical, the sort of psychiatric condition, but it doesn't put weight gain on. And topiramate, for some reason, although it's a seizure disorder medication, we have found seems to help a person lose weight. I'm not talking about a lot. So these medications, and in fact, all medications, are at best about 8% of body weight loss. So that means if you're 200 pounds, that's, what is that, like 10 pounds maybe? At the best, 15 pounds. That's a lot of, that's not very much for, taking medication. And some of these are not cheap. Some of the consequences are, some of the antidepressants can cause sedation, and believe it or not, some can even cause anxiety. Weight loss, as I said, is at the best is 10%. You can actually increase your weight with some of these antidepressants, which is why, if you noticed, I use the word weight neutral for some of the antidepressants, like Wellbutrin. They are weight neutral because some of them will actually make you gain a lot of weight. All of them seem to decrease libido, which is, that's another big cost. And some of the ones that seem to be very promising, and you'll see if I go back here, if you look here where it says off market, we had something called Fen-Phen and Meridia. These were drugs that looked like they were better than that 10%, but they caused some fairly significant heart valve defect problems, so they had to be taken off of the market. So there's those. Craving blockers are, the idea is, can you take a drug that will diminish the effect of the food that you're eating so that you won't care? It's like for example, Revia, which is Naltrexone, is a drug, a craving blocker that we use often for alcohol, so that if you take this drug and you have a drink, it doesn't give you quite that buzz, so you're not really going to want to keep drinking, because it's kind of flat. It's going to flatten the buzz, and theoretically, it will flatten the buzz of the sugar, so you're not going to be wanting to eat bad foods. Rimonabant, which is no longer on mark, was very exciting. This was, I think, in the 90s, because it was an endocannabinoid blocker. In other words, if you don't know what that is, think about if you've ever smoked a joint and you get the munchies. Well, this is the anti-munchie pill. It doesn't make you want it much, but then they found that it also made you not want to live, and there was a high rate of suicide, and so it got taken off the market. There's a couple of other drugs. We see them a lot in the addiction field, one called baclofen, another one called gabapentin. We don't know why, but they are used for craving. They seem to help some of the time for alcoholics and cocaine users. And so they're used because it's the principle that if you're eating addictively, maybe they'll help for food addiction too. So they're being used too. I don't think with great success, but anyway, there they are. That's the thing with medications. It's unlike surgery, there's not a lot of huge success, but it's better than nothing, I guess is the idea. Now, we've got a couple of drugs on the market. I've kind of given you some of the background. So now we're seeing these combo medications, and these are the ones that are sort of the new exciting kids on the block, as it were. There's one called Quizmia, which is basically an appetite suppressant, like a bit of that speediness, with topiramate, which is an anti-seizure medication that has weight neutral effects, or even weight lowering effects. Not really sure why that works, but it's a sort of it's been around for the last few years. The FDA have finally approved it in the US, and I think that its success rate is somewhere around the 8 to 9% body weight loss. Still not a huge amount. It's a pretty expensive drug because it's new. There's no generic version of that. It's only brand name, but there it is. The next drug, Contrave, is a combo of the Wellbutrin, which is the weight neutral antidepressant, and Naltrexone, which is the sort of flatten the euphoric effect of any drug. Put those two together, and that's another one. That's probably the closest to a food addiction drug that there is. But I think its success rate is somewhere around 6 or 7%. It's a body weight loss. So we're not talking about a lot of weight loss here. the most exciting in the area, if you're a pharmacologist or you're interested in drugs, is in the hormonal area. And it fits that it would be interesting here, because if you're following a low carb or keto plan, the reason why that you're losing that weight that you are, and hopefully maintaining it, but if you're not, then that's probably why you're listening to this talk. It's because of the hormones. It's mechanically, chemically, hormonally altering, readjusting the hormonal disarray that the processed food industry has put your hormones into. And so a low carb food plan is perfect, which, by the way, means you don't need to take medications. But if you're going to, these are all of the hormones that can get affected, or pills that will affect hormones, especially if you don't want to change your diet. So, leptin is our hormone that gives us that feeling of satiety. So why not take a drug that will give us a feeling of satiety? That's leptin. It actually is, I think it's past its heyday. That was very exciting about 20 years ago. And then they found out that it didn't actually work that well. Metformin is a standard a medication for diabetes. And what it does is makes a person their hormones more insulin sensitive, because they're diabetic. And so diabetes means that you have insulin resistance. So you're taking a medication that improves or deals with that resistance and makes you more sensitive, and also makes it so that you don't make as much sugar, in your own sugar. It's called gluconeogenesis. It will suppress that through a glucagon effect. So metformin is a drug that's used, and even it's been standardly used only for a diabetic or a pre-diabetic, and now we're starting to actually see it in normal, normal sugar people. Often people who are on medications that will actually alter their diabetic profile. Synthyroid is for thyroid, and there are some people who have normal thyroid. It's usually in the naturopathic world where they'll try to up their thyroid, because thyroid is the hormone that sort of regulates our body chemistry, our body, our metabolism. That's the word I'm trying to get. It regulates our body metabolism. So if you're hypothyroid, which is what a lot of women, especially postmenopausal, are, then you take thyroid to sort of balance that. And now there's even some thought of, well, could we just up a person, even a normal, what we call euthyroid, can we just up that a little bit? One of the most exciting ones that are being talked about is this new drug called Saxenda, and that I have a separate slide for that. It's called liraglutide. So Saxenda is kind of like a fancy version of metformin. It improves insulin resistance. It seems to delay gastric emptying so that you're not hungry as quickly, and so therefore you're not going to eat because you feel full longer. Saxenda has been approved for weight loss. It's one of the main drugs now that's being pushed that is approved for weight loss, although there is a version of it called Victoza, which is just for diabetes, but you don't have to be diabetic to take Saxenda. And the success there is about, again, 5 to 10%. Now, this is a daily injection for as long as you want to be on this. That could be the rest of your life, or they basically say if you haven't lost at least 3% of your weight by 3 months, then it's not working. Don't bother. But that's a pretty heavy duty commitment. A daily injection. There's another one now called semaglutide that's just come out, or otherwise known as Wegovy, and that is a once a week injection. And the weight loss seems to be even higher, up to 15%. It's probably one of the best ones right now. I think that's the one that is getting people very excited. 15% of body weight within 3 months or so. That's pretty good. But it has a lot of negative side effects, like bowel, like constipation and nausea and stuff like that. So you are paying for it in one way or another. But okay, so basically, why are these not helpful for the food addict? Well, for one thing, we're talking about the surgery or the medication. If you're using it like the surgery to make yourself feel full because your stomach is smaller, Food addicts will eat whether they're hungry or full. It's not about satiety. It's about being driven to eat because there's this itch, this desire to eat more. It has nothing to do with satiety. And in fact, feeling full is an annoying feature of a food addict. It's like, oh God, I'm full already, and I've got a whole night ahead of me. The next thing, food addicts have often lost hunger cues. So if you're thinking of relying on that feeling of satiety, the person has lost that sense of what does hungry feel like. If you're grazing throughout the whole day, you don't even know what hunger feels like anymore. Food addicts will eat whether they're happy or sad, or so, food addicts eat regardless of mood. Happy, sad, glad, whatever, it doesn't matter. Mood is often a consequence. It's definitely a player, but you can eat just like the alcoholic is celebrating. The food addict they go out for dessert because they got something and they're super happy. It has nothing to do with that. The thing about all of these suggestions, the next one here, food addiction is chronic and progressive. All of these medications, they only work while you're on them. And the surgery has also like if you end up eating and then becoming more potentially addicted to something, the profound positive effects go unless, especially if you stop using the medication, the weight all comes back. And if you continue to eat, and so your body just adjusts despite the surgical alterations, the weight still comes back. So for the food addict, these are all temporary solutions. And food addiction is a progressive, chronic condition. It doesn't go away. Okay, and then finally, I just want to say that because it's addiction, it's not just about the food and about the eating. It's about the cues. It's about living life in the world where there's cues to eat sugar and food all the time. It's just not enough. So in summary, I'm going to say that surgery and medication may be helpful, but surgery, for sure, you'll get more, but it's only good for a while, and then the weight comes back, unless you have a food addiction mentality and a plan that addresses that. And the medication, the results are tops 15% weight loss. Now, I want to tell you something, that if you follow a food addiction plan, you can lose 100 pounds, and you can keep it off, not by forever, as long as you're eating foods that are appropriate to your specific needs. So that's basically it. Surgery and medications, good, but only as tools. And if you don't have a concept of food addiction, then you will undermine any good that has. But if you do, then these might be very useful tools. Okay, so I think I'm available now for any questions and comments that people have. And then again, hang tight, because we have a great announcement that we want to give at the end of this class.
Hi.
Hi, Lisa.
For those of you who don't know me, I'm Lisa with Adapt Your Life Academy, and I am going to be helping Doc with questions and the exciting announcement that we have at the end of actually, while we're waiting for questions, we can see your side chat, and we're busy streaming into 8 groups. So can I ask you to please use the hashtag in all caps question? So use the hashtag and then question followed by your question, and then our team will be able to pick up your question a lot easier. Before we go into Q&A, how about we announce our exciting news right now, and then people will have more questions as we go.
Sure, I'm happy to do that. Okay, so the big announcement is that I'm going to be doing a talk on sugar and food addiction. And I want to tell you, first of all, because I forgot to tell you earlier, that I am myself a recovering food addict. So I'm super excited about this, because I can tell you that this is exactly the information I would have wanted to have 30 years ago. And, all of us, even though we have information, we say, I don't really want to do that. So I can't say that I would have saved 30 years of my life, but I think I would have saved a good 10, which was just through ignorance, just through thinking, if I do, maybe I should do that surgery, or maybe I should take that medication. I wouldn't, now I know, well, okay, that would be fine, but I have to have this information. So this course that I'm doing, this is the first time I've pulled all this information together. I've spoken many times on different venues and taught, but I've never pulled all this information. It's kind of like everything I know about sugar and food addiction. And what I'm going to do is talk about, first of all, the science, the validity of that concept of food addiction, that it does absolutely exist. We have the science. There's a lot of naysayers who say that it doesn't exist. It does, and I'm going to bring some of that out. I'm going to talk about the biology of that, of food addiction and sugar addiction, and just tell you why it happens so it makes sense to you. And I'm actually pretty good at making things simple. And then I'm going to talk about how do you know that you're a food addict, give you these sort of questions and answers. And by the way, if you're somebody who did those questions that we had in our first email, and you said yes, this is the course for you, because this is all the information that you're going to need. And if you're somebody who related to this course, this class that I just did now and a couple of days ago, again, it's going to be useful. And even if you're thinking, I don't know if I'm a food addict, but I'm eating my low carb and keto, and I keep stumbling back and forth, slipping on foods and whatever. Even if you're not a food addict, you're going to understand why you keep slipping and how to stop slipping so that you don't become a food addict. I think this is a course that the whole world should take, if you don't mind my saying so, Lisa.
Not at all.
Okay. So anyway, so there, I'm going to talk about, am I a food addict? Then I want to talk about, okay, if you decide maybe I am a food addict, then where do you fit in the spectrum of food addiction? Because there's different stages of food addiction. I said earlier, it's a chronic progressive condition. Where do you fit in that whole spectrum? Because depending on where you fit, that's going to depend on what's the best solution for you, which is, of course, the next part of the class or the course, which is talking about depending on where you fit, what is the best option for you? Like, what foods should you, what you would decide are trigger foods, what you can get away with, what you can't, and then you can design your own plan using this information. And then finally, once you figure out what we call food sobriety is, then, and of course, we're going to focus on the idea of this is an addiction. So you've got to figure out what does food sobriety mean? Well, it means probably abstinence of sugar and flour, which most of you probably already are if you're following a keto or low carb plan. But then also other things that might slip in, you'll realize I have to be abstinent from those. Okay. And then finally, when you've got your food addiction, food sobriety plan, how do you stay sober? So in other words, focusing a lot on the relapse prevention piece and the importance of that, and some of the sort of pitfalls there and how you can protect yourself. So overall, this is basically everything you want to know about sugar and food addiction, so that you can prevent yourself from going further down that road, or if you're down that road, how you can understand why you're there, because this is not about willpower. Believe me, this is a biological phenomena that happens, but there's something that can be done. And the end result, and I can tell you this as a recovered food addict myself, you can, I'll just end with this, you can be in a situation where you love every bit of food that you're eating. You're not feeling deprived, because you figured out what it's the trigger foods that make you feel deprived. So once they're gone, you're going to love the food that you're eating, and you're going to stay a weight that is stable. I lost 100 pounds more than 10 years ago, and I've never gained it back. Like, this is not like in 5 years or in 10 years post whatever it comes back. No weight regain, because I get the concept of this, and it's not through any sweating on my part. The only sweat I have is that people's ignorance, and that's why I'm so keen to talk about this topic. And the ignorance is not because we're ignorant people, but because we're not told this stuff, and the food industry has no interest in telling us this. But we have an interest in giving this information to you. So I'm super excited, and I hope you are too.
Yeah, it's an amazing course, and I'll go into a little bit more logistics at the end of the Q&A. But basically, we've opened enrollment kind of right now today. We have opened enrollment. It's only open for a limited time, so we close enrollment on May 1st. And if you want to learn more about the course and exactly what's inside the course, our team will post a link to the food and sugar to the sugar and food addiction page, and you'll be able to see exactly what the course entails, all the lessons, all the modules, etc. And then, of course, during the course as well, there is also 3 live Zoom recap and Q&A sessions with Dr. Tarman, and I'll give you those dates as well, and kind of just tell you a little bit more logistically on how it works at the end. But let's get into the Q&A, and then we can answer kind of the more course type questions at the end. So hold on one second. All right. Kenworth wants to know, does an insulin spike store calories from the small intestine or stomach?
Ask that question again. Does an insulin
spike store calories from the small intestine or stomach?
I'd have to say I don't know.
Okay. Gwen says,
I think the insulin spike does store calories, but I'm not sure about the small intestine or whatnot. Yeah.
Gwen says, will we be given a food plan to start with? There is a bonus. Dr. Westman gives a bonus in this course, and you will have access to a food list and Dr. West and an entire video from Dr. Westman inside of this course as well in your student portal.
If I can say, Lisa, that a pure, like a Dr. Westman, pure keto plan is an excellent food addiction plan. It's what happens is that people start to tweak that, and they start to try to introduce some things that are still low carb, but they're not, they're triggering. And that's the piece that gets people thrown off. And we will talk about that.
And just to reiterate and continue on that point is, a lot of people think that keto is an 80% fat way of eating. And the way Dr. Westman teaches low carb keto is according to the science, not according to what we call internet keto. So if you're in these groups all about keto, or you don't really know that much about keto, what we teach, what Dr. Westman teaches, is not what you think it is. It is fat is very much limited on this plan, and it's a low carb. Protein is a priority, and we explain all of that. Dr. Westman will explain this in his video. So, when we talk about keto, don't think, keto is we're going to put you on an 80% fat plan type of thing. Absolutely not. Let's see.
But yeah, okay.
Sue says, my doctor said I have to get bariatric surgery. He said I can never lose weight with diet and exercise.
Yeah, this is the thing. And I understand why they say that, but it's because they're promoting the wrong diet and the wrong exercise. You're right. You're not going to lose weight if you're following the calories in, calories out model. But Susan, ask your doctor if he believes in the low carb food plan, or I mean, this is the whole thing. It's all about, it's not about calories. And that's exactly, this is the standard medical advice now. In fact, most doctors will now push surgery and medication, and will not want to talk about medication because they're afraid, because they know it doesn't. I'm sorry, I talk about diet because they know it doesn't work, and then they essentially are fat shaming the person. The person doesn't want to go back because they're embarrassed. The diet doesn't work. Well, the diet didn't work because they're using the wrong diet. And
also, don't forget, it's doctors only know what they know. I mean, most doctors today have taken maybe a half an hour's course on nutrition. So what doctors know is all about medication and surgery. That's what doctors know. They are definitely not, most of them, I'm generalizing here, but they are definitely not up to date on the latest science when it comes to weight loss and addiction. So it's very important that you know that. Garden Girl says, what is the Food Addict's food plan or way of eating?
Well, it's to put it very simply, it's recognizing what are your trigger foods and eliminating them. And so it's going to be different for every person. Like a vegan who is not a low carb necessarily, but if they're attentive to the carbs that they're eating, not eating processed stuff, which is highly triggering. It's made to be triggering. So if you eliminate that, you still get away with eating a fairly moderate carb. That's not going to be a high carb, because in relation to general population, refined foods is high carb. Eating like a vegan style is probably more moderate. It's or very liberal low carb. It's not keto by any means. You have to basically remove refined triggering foods, and you'll decide what those are for yourself, and then abstain from those. So I can't say there's one plan. I'd say that there's more one approach.
And we cover this in the course. This is
Yes,
all covered in the course. And this is, again, a question that is covered in the course. It's very difficult to just come up with sort of one or two sentences of an answer, because this is a very complex issue. So, for example, Teresa says, what are some resources to help me stay on track and solve issues with cravings? It's not something that we can just talk about in a sentence,
But it is in the course. Yeah,
absolutely. Go ahead.
I do a whole class on just relapse prevention, or a whole talk on just relapse prevention, which includes a lot of that stuff. Yeah.
Pamela says, will this course help if you're taking medication with a side effect of weight gain like prednisone?
Oh my gosh. Yeah. Prednisone is a pretty serious one. Yes, it will mitigate the effects of the prednisone. It can't make it go away, but at least you'll know you're doing the best possible that you can while you're on that medication. Yeah, I feel very badly for you. Prednisone is we used to give prednisone for HIV patients in the 80s just to fatten them up because they were losing weight. Like it's a hard one, prednisone.
And Erica says, why are food scientists allowed to work on maximizing the addictive nature of food?
That is a highly political question, and I'm with you on that one. I don't think I talk about the politics of food addiction, but in the 70s, we used to say the personal is political, so the personal is the food, but it's very political. And so, yes, why? Because why do cigarettes? Why is the cannabis industry so big now? Because it's highly profitable, and it's at our expense. I'll just end this bit. Marion Nestle, who is a food writer she's still writing now, but she was really big in the 80s, 90s. She said, food science, it's not a social service industry. It's a profit industry.
Mm-hmm. Yeah. And that's the same as, we teach, Dr. Westman teaches as well when it comes to food labels. I mean, you go into the store today, and it is almost a crime to see that these foods are saying heart healthy and sugar free and all these things when you look at the ingredients and the labels, and quite the opposite, and that's what Dr. Westman teaches as well, is really how to look at reading labels and what to be aware of. I think that, I'm a recovering 4 years recovering binge eater and food addict. And, it's taken me a long time. I mean, it's taken me a long time to grasp what we were taught as kids and growing up. Our parents didn't understand food addiction, and they didn't understand food labels and things like that. I mean, if you're in the place that you're in now, you have found Dr. Tarman, you found Adapt Your Life Academy, you found us, and everything that we do is based on the science. So already kudos to you for even finding us versus going onto Facebook and looking at a group that is kind of talking about internet keto, and there are hundreds of thousands of people in these groups that are doing things wrong, Dr. Tarman, but they think they are doing them correctly.
Yeah, that's right.
It's just so sad, it's just so sad. So it's not just one little aspect. You almost need to understand the full puzzle, all the pieces in the puzzle, and then you can move forward, and that's why a course like Dr. Tarman's is so important, because she succinctly puts this together, all the different pieces, understanding where you are, knowing where you are and how you got there and why you got there. And then you're able to move forward and make the right decisions based on the science versus the internet noise,
Mm-hmm.
Um, J. Rowe Love says, are there inpatient programs?
Oh, yeah, God. You know what? This is economics now. Until we get food addiction approved by the DSM-5, which we're the DSM-5 process is a lobbying. It's a lobbying process, and scientists have to come together with all sorts of research and make their case. And we're still making our case. And until that happens, insurance won't fund food addiction. And there was an inpatient food addiction program called Glen Bay in I think it was the 80s. And then it ran out of steam. It ran out of money 10 years later. It was a great program. And now the best, and I work at Renaissance here in Toronto, Canada. We had a food addiction program for 3 years, and the money ran out. And our government, although we have a lot of healthcare services funded by the government, not that one. So there appears to be times when there is an inpatient program, but right now, today, the best that we have are these sort of 5-day intensives where you might go somewhere and live there for 5 days, or it's an intensive program. Now, with COVID, some of those intensive programs went online, so that you were literally in front of the computer for 8 hours eating your meals. It's a long time, but like you are sort of glued to your monitor for the day. But is there something inpatient for like a month? Right now, I'm not aware of something. Now, I will say that there's a couple of programs that are for eating disorders, and they've managed to kind of squeeze in a subpopulation of food addicts in. But you have to kind of walk in the door saying, I have a binge eating disorder, almost like food addiction quality or subtype. And let me see, what is it called? Shades of Hope. No, I can't remember the name offhand. But anyway, there's a couple like that. But what you're asking, not yet. We need something like that.
Sarah again says, is the solution similar to Overeaters Anonymous? I recognize my addiction, but Overeaters Anonymous was a struggle for me.
Yeah, so that's a very good question. So the 12-step program, addiction, I'm in the addiction field, and there's alongside medication and alongside treatment programs, we have the 12-step programs in the community. And sure enough, in the food world, we have, I think there's like 10 food addiction groups. And I actually talk about that in the course as well. So Overeaters Anonymous is the oldest one, and it's in a way the most liberal one. So it often, unless you find a group that you really like, that works for you, often people have to go to a few of the others. There's another one called FAA, Food Addiction Anonymous, another one called Gray Sheet Anonymous. They're more structured and give a food plan, and they're, I want to say, more successful because they're so intense, versus OA, which is not quite that intense. A lot of people will actually, instead of going to a food plan, will go to AA. And instead of saying, hi, I'm Vera, I'm an alcoholic, they'll say, hi, I'm Vera, I'm an alcoholic. But what they really mean is, I'm a food addict, because they find that the structure of AA is better often than OA. OA is a hit and miss unless you find a great group, because there are some really good groups.
CJ says, do you cover the stinking thinking aspect of food addiction?
Oh my God, yes, I do. The lies that we tell ourselves. Yes, that's a very astute awareness. And that's partly why it's not just about the food, like the doctors, like with medication and surgery. Yeah, you can get that. That's fine. But if that stinking thinking is there, you're going to find a reason to slurp up your calories, even though you're taking the medication and you've had the surgery. You have to deal with the stinking thinking. Yes.
Marty says, I signed up for the course. Great. Do we start taking this course today? I will talk about that, Marty, because once you purchase the course, you actually do have immediate access to your student portal and your lessons, etc. But I will talk about that logistics kind of at the end of this Q&A, so hang tight on that one. Question from Gwen: is cheddar cheese and nuts a problem for most food addicts?
You see, that's why this course is so important, because it's not just about sugar and refined carbs. Depending on where you are on it's a great question, thank you. Depending on where you are on the continuum of food addiction, you might be already moving along the line where you're kind of in that later stage. So that's foods that were not a trigger 10 years ago are now a trigger. And cheese, especially cheeses like cheddar cheese, and nuts absolutely are become trigger foods. So even though they're not refined, they are, and even though they're proteins and they would be keto perfect, that's why I'm saying, like, if you have a great keto plan and you find that you're stumbling, it's because something else is triggering it. And it's not just about the refined. So you want to find out what that is. And yes, those are in a gray area where many people find that they can't. Like I can, for example, I can eat soy nuts, a few. I have to portion them out, but I can't eat cashews anymore. Oh my God, I'll eat the whole bag of cashews.
Me too.
Yeah, and peanuts. So they're just out. They're just out. But
Yeah.
I don't care because I eat stuff I like. So anyway, that's the answer to your
And
question.
it's so important to be honest with yourself and know yourself, right, Doc? I mean, you have to know yourself. I mean, I know that if I have a bag of carrots in front of me, even, and I can, it's impossible for me to stop at 3 carrots, and the same with nuts.
Mm-hmm.
So you just don't have those foods around because you know that is your trigger,
And we'll talk about that, like how to not get triggered like that, because it is more than just the food.
Absolutely. And then she actually says here also, what about behaviors like snacks? These are all things that we talk about in the course, right?
Cues, yes.
Yeah.
People, places, things, snacks.
Yeah.
No snacks.
100%. Question, Anna says, is there a private Facebook page for the course? No, there is not, Anna. You will be given your own private student portal. And then inside of your student portal, there are Zoom sessions that I will cover at the end. There's going to be 3 Zoom sessions with Dr. Tarman, and I'll cover all of that at the end. But there is no Facebook page or group. Let's see. Roseanne says, if a person needs more help with Dr. Tarman after the course, is that going to be possible even if it costs money? She would be interested. Thank you for the great presentation. Thank you, Roseanne.
Okay, so I'm going to answer that by saying that I'm in Canada and I'm not allowed to consult with people. It's a legal medical legal thing. I can't do that. I can give you ways that I can be. I guess I'm going to say no in the context that you're asking. No, I am available on the Zoom calls, but I cannot be used as a consultant.
Yeah,
it's very unfortunate because we had a food addiction plan and a lot of Americans wanted to come up and we couldn't take them because of this whole Canadian medical legal issue.
Right. Jacqueline says FAA has a food plan that is too high carb for one with metabolic syndrome. Mm-hmm. My endocrinologist said, which your endocrinologist is correct. Great. Do you think that high carb plan is good for food addicts?
Well, that's an example of a vegan a person or a plant-based person is going to be eating a lot more carbs than a keto. Yes, I think so, but it has to be done with care. So you have to be really careful that you're not eating refined foods. But like I for example, am not a keto eater quite to the extent of 20 carbs a day because I eat a lot more vegetables. But they're vegetables; they're not refined. Like they're raw vegetables, and that's no problem. So you have to be more. Once you have the concept of food addiction and what's addictive and what's triggering, you can kind of move into a higher carb, but it's not going to be anything like the refined carbs that, the general standard American diet is, which is like 100 plus. It's not anything like that.
Okay. I think that Judy says, had COVID January 4, still can't taste or smell anything. I seem to graze trying to get satisfied from taste of food, but I can't smell or taste bacon as an example.
Yeah, that's unfortunately a lot of our taste comes from our smell, and if COVID has damaged that, I'm hoping that will come back. I've heard people that have had that, but it's come back. You won't be able to. Unfortunately, you're going to be drawn to eating more refined, which is more potent. You're going to be drawn to that. Really try to not, because you're going to pay for that. Obviously, with food addiction, like, the addictive nature of that stuff is still addictive, whether you like it or not. That's the thing about what with addiction is, the more you get into it, the less you actually like your eating food, and the more you're chasing the dream of that food, which we call chasing the dragon.
Rosalind says, is Ozampec used for weight loss? I was told it helps.
Yes, Ozampec is one of those exciting hormone medications. It's that most recent one, semaglutide. It's the one that has the most promising. I think it's 10 or 15% of body weight loss of what's out there now. But it's quite expensive. I mean, and it is injection, and it only works while you're taking it. If you wanted to take something like that, then good, because you might jump ahead of the queue and losing your weight, but you've got to follow a food addiction plan, because you'll just gain it all back. The best way to use medications in surgery is to just get a head start, but then have a plan that will keep it maintained. And it's possible, but it's not going to be the medications that will do that.
Doc, we have about 2-3 questions left. How are you doing on time? You good?
I'm good with that. Yeah.
Okay. Let's see. Judy says, any advice for managing a house with elderly parents whom need the calories? Can't restrict food in the house. Often I cave due to the ease with managing the house, quick and easy.
Yeah, that's really hard. But if I can ask you to just reframe the food that you're offering, if the person can't eat the food because it's like real food, because it's hard to eat, they have dental problems or something, can you mash it up or in some way? But you don't want to give refined foods, because you're not really giving them food, you're giving them empty calories, and the weight that they will gain is basically what's called it's visceral obesity. It's what creates metabolic syndrome. It's what creates illness. So you want them to gain weight, but you want them to gain weight of the non-refined carbs, but or eat more fats or eat more proteins. You don't want to eat the refined carbs, even though they're easier. And I understand that it's actually more, it creates ill health, which you don't want to do. How to talk about to make it more easy? That's a lot of that is making one day where you just prepare all of that stuff, and then you can just pull it out of the freezer that day. Hire somebody to do that, to do the chopping, if you can't do it. I don't know.
Good idea. If you've got the money, absolutely. I'd love to hire a chef to come and cook all my meals.
Well, I'm just thinking, like, for 4 hours in the day, all that legwork of chopping all that stuff. Or you can buy, riced cauliflower and sliced carrots and stuff like that.
Yeah, we actually also teach as well the prep. The prep is really important. If you can pre-prep sort of at the beginning of every week, so that during that week you've got all the protein and all the everything in your fridge.
That's it.
Then you're good. So Katie bought your book and she wants to know if she's going to get more information out of the class. More than the book.
Yes, I think so. Well, the book is, if you're a reader, the book is pretty good. I'm pretty pleased with the book. But what I've done in the course is I've broken down the concepts and fleshed them out. And so it's a real luxury. It's 18 videos, each with its own concept. I'm not able to do that in the book. I have to kind of tell a story around it, and I have to be more aware of attaching references to it. This was more of a teaching module where I'm explaining stuff. So I think you'll get more detail and more understanding about specific things. than the book itself. It's
And
a
then Angie says,
different way of learning. Yeah.
yeah, yeah, some people, it's a different way of learning for sure. And actually, in the course, that's the reason that we have transcripts. We have all the transcripts from the videos as well. So you'll not only get the course lessons, video lessons, but you also get PDF resources and transcripts and a whole bunch more inside of your student portal. Angie says, would this course help someone who has a hard time going even one full day without caving into cravings?
Well, I so understand that. That's an addict. You are a food addict.
Yeah.
I don't know. You might require more structure, but it will give you the two things it will give you is validation that it's not because you are somebody who has no willpower. That it is actually because your brain has already habituated and become so tolerant that it's making you behave in ways that you can't control anymore. So I just to validate that there is a medical thing that's happened to you, which if that's helpful. And then the second thing is you'll just have a better understanding so that you'll know why. And then if there's anything that you can do to mitigate that, like for example, if you know that this is an addiction, then you're not going to go and leave something that's in the house, like an tub of ice cream, leaving it there because you might say no to it now, but you won't later tonight when you're really suffering. But if it's not in the house, like you learn tips and tools to help you. I don't know if it will be enough, but it will be an overview so that you'll understand where the holes are. Will they fill the holes? Maybe not, but you'll know where the holes are.
I think that as an addict, and you and I both understand this because we're both ex-addicts, or probably always an addict, I guess.
Yes, I believe
but
that.
it's important, as I said earlier, to have different tools in your toolbox, so that you can reference at any given time. And this course is one incredible tool to have inside of your toolbox. And then if you want to go further, Dr. Westman, we also do a course. We're closed right now, so we're not offering this course now. The next enrollment is at the end of June, but Dr. Westman also does a Keto Made Simple course. And that very much goes over, again, that's another tool inside of your toolbox. And once you have your toolbox complete, it is unbelievable how you're able to abstain and move forward. And once you have all of this understanding, whereas without the understanding, you're starting your diet next Monday and next Monday and next Monday and next Monday. If you don't go into it, you're always going to be on that roller coaster. Right. So you have to embrace all of this learning so that you can actually help yourself, basically. All right. Last question. And you know what we're going to do is obviously there's questions that we have not answered. And so after the fact, we will go in and answer your questions. So Louise says, where do you feel exercise falls into the plan of addressing my food addiction?
So the exercise can actually become an addictive behavior. And we would actually ask, I think that the best thing to do, this is an addiction, so we want to address that first. It's very easy to transfer the addiction. So often people also want to use exercise because they want to lose weight, and you can be, I'm going to just say this, you can be a couch potato and lose 100 pounds, because if you stop eating the foods that are causing the obesity and the cravings for food, then you don't need to exercise. But what's going to happen is, as you're freed up from not thinking about food all the time, and as your weight is dropping because you're not eating refined sugars and flours, you're going to want to exercise, and you're not going to want to over exercise. You're going to want to. So my suggestion would be, if you are in early recovery, hold on to the exercise, walk, swim, definitely keep active. But the running and triathlons and all that kind of stuff, hold off for a little bit. Often you're just going to do damage to yourself, especially if you're over exercising. I'd be careful with exercise early on, except for walking and swimming and yoga and stuff like that. Stuff that's basically easier, or maybe even some weightlifting, but easy, not for the purpose of weight loss.
Right. And then lastly, Etty says, does denial play a big part in food addiction?
Absolutely. It's one of the cardinal features of addiction. I got this. I'll do it tomorrow. I'm going to quit. I don't need to quit today. There's no point because I've already eaten too much. I'll do it tomorrow. The best time is, you know what? I can't wait for myself to get on board, because waiting for myself to get on board is like waiting for, the addiction to just stop. It doesn't. You just have to do it, whether you're ready or not. And you will come to it. You'll come to it. So denial is a cardinal feature of any addiction, including food addiction. You don't have to call it. I saw somebody else made a note. Do I have to say food addiction? No, you can say food allergy. You're hypersensitive to particular trigger foods. And your hypersensitivity manifests itself to uncontrolled eating. Call it an allergy. I'm good with that.
Yeah. Yeah. I also often say, when people go to restaurants, absolutely say that you have sugar allergies, and, you got to make sure that there's no sugar in the sauce or whatever. Right. There's nothing wrong with that. All right. I am going to talk a little bit. I think we've kind of covered most of the addiction questions. Mm-hmm. So I'm going to talk a little bit about logistics. Do you want me to take you out of the picture, Doc, or do you just want to hang in the balance there, kind of on the side? Up to you.
Well, I can hang in until 7:30. How's that?
Okay. So I'm not going to go too long, because what I want to say is, if you do have questions about the course, first of all, you can email us. And our email is academy@adaptyourlife.com. So remember, we have a 1-week period in which to enroll in this course, starting today through May 1st. On May 2nd, you will not be able to enroll in this course. We will officially be closed for enrollment. And we're not sure at this stage when the next enrollment period is going to be. But what's great about this is, somebody asked, Deborah says, will this course be accessible in the online portal after 3 weeks with Dr. Tarman? Absolutely. Once you have purchased this course, and I'll talk about the cost of the course afterwards, but once you've purchased it, it's yours. It's yours to keep. This version of the course is yours to keep. Mm-hmm. So you will be able to, in 3 months, in 6 months, in 1 year, still be able to log into your portal and have access to the whatever's in your portal right now. You will have full access. And then basically what happens is, as I mentioned earlier, once you purchase the course, you get immediate access to your portal. So you will get a welcome email, and inside of that welcome email, it'll have instructions, and it will talk you through exactly how to get into your portal. And there's even a navigation video and a welcome video from Dr. Tarman inside of your portal. And then you'll be able to go through the course at your own pace. So you can start tonight. You can start tomorrow. You can go in and come back as many times as you like. You can watch the lessons as many times as you like. And so then what happens is, there are 3 live Zoom sessions. And when you're inside of your portal, you will actually see all of your PDF resources, which are quite robust for you. And you will also see 3 different Zoom buttons: Zoom session number 1, Zoom session number 2, and Zoom session number 3. And those Zoom sessions are all recorded, and they are sent to you on the replay the next day, because we have people from all over the world in all different time zones. So if you cannot watch at the live time, which is 5 p.m. Eastern time on a Sunday, starting May 8, which would be Zoom session number 1. So it's May 8, May 15, and May 22. So those are all 3 consecutive Sundays at 5 p.m. But if you're not able to join live, no problem. We will record all of these sessions and they will be sent to you via email the following day. So you will have full access to them. You will also be able to submit questions ahead of time by emailing us through email, academy@adaptyourlife.com. But before you submit course questions, we ask you please to go through the entire course and your resources first before asking questions, because we will probably have over 700 people inside of this course. And if we were to get 700 emails every day, we will be completely overwhelmed. So if you can go through the course and your resources first, we would really appreciate it. Most of your questions are covered inside of the course. So, you will see that they are covered inside of the course, and you should be good. If, of course, you've done the course and you've looked at your resources and you still have a question, then by all means, please submit your question via email, and Dr. Tarman will answer your question during the next live Zoom session. And again, in your welcome instructions, we give you all of this. So you will not be left hanging at all. You will know exactly where to email us. You will know exactly how to reach us, what to do, where to go. And then I'm not sure if our team has given you the link yet, but if not, team, if you can just post the link down below in the comments. But basically, if you go to our main website, which is adaptyourlifeacademy.com, and on the homepage, you will see a big yellow button that says Next Course. If you click on Next Course, it will take you to the page, to the sugar and food addiction page, and you can go through that page. It's very robust. It'll tell you exactly who Dr. Tarman is, what the course is about, all about your lessons, your modules, why this course is for you, if this course is for you. It will cover everything. So by the time you purchase the course, you will know if this course is for you. And get this, guys, this course, and it's over 15 lessons. And how many hours is it, would you say, Doc?
It's between 3 and 4 hours. Yeah.
In total.
Yeah.
And that's just the video lessons, right? Mm-hmm. There's still a ton of resources in there. This course is being offered at a one-time founding member price of $167. If we specifically made this course $167 for the very, very first cohort, because we wanted to make this as accessible as possible to as many people as possible, especially coming out of this COVID situation that we've just come out of. You know, a lot of people are struggling financially, or they've lost their jobs, etc. So it was very important to us, our team, Dr. Tarman, to have this course be accessible to the most amount of people. It is worth a hell of a lot more than $167 if you think about what Dr. Tarman's hourly rate may be. So you are getting this course at an absolute steal, and this is probably the very last time that you will ever get this course at this price again. So I would highly encourage you to look at that page. If you see that this course is going to help you on this page, we are not saying buy the course, by no means. But if on this course, Dr. Tarman is covering exactly what you need inside of this course, then it is a slam dunk for that price that you need to take this course. So please go to that course page so you can see exactly what the course entails. Does anybody have any other questions? Let me see on the actual course itself, and how does the course work, logistics. Anne says, I consider it a true bargain. Thanks, Anne. Anne's been in one of the Academy's other courses. So thank you for that. Considering how much I've spent on feeding my addiction. Absolutely. Let's see. The course is reasonably priced. Absolutely. I see that the course info has been posted. And in fact, it's been posted, the actual page, the sugar and food addiction page, the URL has been posted. So you don't even need to look for that course inside of the Academy. That page has been posted. And I think people are saying they're excited. We are so excited for you. Honestly, this is an incredible course. You've got an amazing teacher, Dr. Tarman. Can you, for those that don't know you, Dr. Tarman, can you just tell people exactly who you are in Canada? You know, that who you are. I know that you're the director of blah, blah. And if you can just kind of talk a little bit about yourself, that would be awesome.
Okay, sure. So I live in Toronto, Canada. I live in Toronto, Canada with my little doggie.
And your kitty.
And my kitty. I love these creatures. They're my therapy animals. And I have I've been working in the field of food addiction, I think for the last 15 years, politically as well as clinically. And as I said earlier, I'm a recovered food addict. I've been struggling with my own issues. I think, well, since my 20s, like so many of us, you know, in university, trying to control our weight. And it wasn't until I got into the addiction field and just saw the connections, which was around, I guess 15, 20 years ago, I started to make those connections. And then just not exactly on a whim, but I just said, I'm going to treat this like alcohol. I'm just not going to have sugar anymore. And thinking that I would suffer, which of course I did for the first few weeks, it was so freeing. Like, really, the message here is that you can be, however you do it, whether you take this course, buy the book, just there's a lot of more and more people are talking about this subject. Just find some way to get support, because you will walk out of this experience with feeling free, as well as not worrying about your weight anymore and loving your food. Like, there really is a positive, a happy ending to this story. And there's a happy ending to my story, because I no longer struggle, and haven't for the last 15 years. Now, I have found that as I get older, you know, menopausal and whatnot, I've had to cut more and more stuff out. So I don't eat sugar, I don't eat flour, I don't eat grains anymore. I used to be able to eat grains, but I don't anymore. Definitely can't do the nuts anymore. There's a real classic example of denial, of thinking, yeah, I can have those nuts, but no, I can't. But, you know, always honoring that has taught me that this stuff really makes a difference. It made a difference in my life. And I see it every day in my treatment centers, how people transfer addictions from their cocaine to their, or tobacco to their food, and then they suffer just as badly. And I can tell you, I've had crystal meth addicts saying, it was hard to quit the crystal meth, but it's harder to quit the sugar. So this is a very serious condition.
You almost have to pick your heart. Your heart, right?
Yes, exactly. Pick your heart. But there's a positive ending at the end. And it is not that you're just going to now smoke dope instead or drink instead. It's going to be that you're going to be free, and you're going to have all sorts of time to be able to do that exercise and, you know, all that stuff on your bucket list besides, you know,
and knowing this, guys, I mean, knowing this gives you hope, because so many people feel hopeless.
Yes.
They've been on this roller coaster all their lives. They don't know. They've tried on their own. It just doesn't work. You know, you have to have support. You have to understand all of this. Otherwise, you will continue on that roller coaster, unfortunately.
That's right. Yeah, it is really a message of hope, and I really understand the hopeless feeling. Like, I totally get that.
Terrible. I totally get that too, because also, me as an ex binge eater, no matter how many times, Doc, I would say during a binge, that is it. Like that is it. It's almost as if I had an evil twin that would push me to not listen to that.
Yeah.
It's almost as if I was fighting with myself in a way.
Yes.
And it's not pleasant. It's just you cannot live like that. You have to take control. You have to take control. And this is what this is giving you, is teaching you how to have that control and to take control back, Marty says, is the hub different from the student portal? Yes, the hub is completely different and has nothing to do with the student portal. The student portal is the portal, your portal of courses, Marty, whereas the hub, for those of you who don't have never taken a course from the academy before, the hub is something completely different and has got nothing to do with courses. So we can talk to you about that privately, but that is basically it. Sugar is the gateway drug. Cocaine, crunch. Anyone? That's quite right, Erin. People are just saying thank you, Dr. Tarman. Thanks, Dr. Tarman. I guess people will be able to go onto this page and see if this course is for them or not.
Yes.
We've posted the link, and we look forward to seeing you in the course. I'm going to be on with Dr. Tarman during the 3 Zoom sessions to help her with a Q&A and to kind of co-host with her. So I will be fielding a lot of your questions. I will be looking at the questions that you've submitted via email, and you will be working with me quite a bit as well through email. And I look forward to seeing you in the course, and I'm excited for what's to come for you.
Right on, and join the revolution. We're gonna fight back big sugar.
100%. Thanks, Doc. Have a good evening.
Okay.
Thanks, everyone. Thanks for joining us. Bye.